And it is 8:15. Good morning to you. I've been looking forward to your joining us for a good conversation from Christus Mother Frances Hospital and one of our physicians. And with us is Dr. Matthew Johnson. Good morning.
Good morning.
Tell us what you do at Christus Hospital.
Sure. I am an anesthesia-trained, board-certified pain physician, interventional pain, and we provide all types of services for patients who suffer from mainly chronic pain, but also acute pains that may come up for a lot of our established patients.
So there's a difference between acute and chronic?
There is. So the definition of acute pain is anything that is within less than a 3-month period. Once it extends beyond 3 months, then it is considered to be a chronic pain issue. And in some people's cases, if it's beyond, 2 weeks, it's like, oh, it's chronic enough for me to come see Dr. Johnson. So, we treat patients really on a broad spectrum relative to pain, because when patients are dealing with pain, that's really the number one driver that sends them to the hospital. So we try to do everything we can to, accommodate them in that way when they're suffering from something that can really be, in some ways, life-changing, life-altering.
So pain might be joint pain, or it might be
pain from
muscles.
Head to toe. So it can be anything from a headache to joint pain, like you mentioned, back pain, neck pain, any pain that can change a person's perspective on their ability to be able to manage and do functional activity that they would normally be able to do without the pain. So if it's I guess a lot of people will come into my office saying, I threw my back out, and what they're not realizing, that some of that may be muscle strain, but some of it also may be due to just arthritis that has flared up and caused them to now have to deal with one of those things that we all try to avoid, is issues of father time.
Oh, this is true.
Yeah, and with that, we try to do the best we can from a medical standpoint to help people live active lives, because a body in motion will stay in motion, and that's something that I always tell my patients. The patients who are more active really see me a lot less, but with how COVID has really driven a lot of patients and a lot of people into their homes to not be able to get out. And, we're able to actually get out more now than we were obviously a year ago. But I see more patients who are unfortunately stricken with that sedentary lifestyle, and that just works against them being able to really mitigate a lot of their pains that we see.
What do you use? What sorts of tools do you use to determine what is causing a pain? Let's say in our abdomen, let's say.
So in the abdomen, that's one of the more nebulous pains that can come pretty much from anywhere. So people who suffer from abdominal pain often may have a issue related to the muscles around the abdomen that can produce a localized sharp pain, or they can have more of a pain internally that can prove to show more of a visceral pain. Now, the visceral pains don't have a pinpoint location as to where they're coming from. And what we see with those patients is that, through a number of injections, we can actually help reduce some of those pains, both visceral and musculoskeletal, to help reduce their overall pain disposition.
So there's different ways that you might see into the problem.
Right, yeah, you
area.
you had asked about some diagnostic tools that we can use. The modality by far that we utilize is advanced imaging, like an MRI, CT scan, or an X-ray at the very minimum. Okay, and I end up ordering a lot of those modalities to help try and identify and really pinpoint where that pain may be coming from. But when it comes to patients and where their pain is, that is not a definitive, like 100% surefire way of being able to treat a person's pain. I can get advanced imaging and MRI of a patient's lower back, and it can say up and down that they have what's called degenerative disc disease, and that's where you have an issue where portions of your disc have now started to deteriorate, where you may have now a bone-on-bone effect. and you'll look at an MRI and it just looks terrible. All right. But the patient's coming in for neck pain.
Oh.
They have absolutely no issues with their lower back at all. Their back is fine, but their neck, which shows clean on the x-ray or an MRI, is giving them some lightning pain that's shooting down into their arm to where they can barely use their hand without any stricken pain. Okay, you don't see any bulging disc, you don't see any issues of any nerve impingement or anything like that from bone spurs. And I see that more times because, you know, those modalities of imaging have a limitation to them. They're still very useful when we have, you know, a bulging disc that's pressing on a nerve, but when it's not, you know, you still have to look at the intangibles is what I call them, which is the microscopic inflammation that doesn't necessarily get picked up, you know, by an MRI or definitely not by an x-ray. But these are still useful tools that we use to guide us when we actually speak to the patient, do a physical exam and evaluation and history, and we're able to actually get a further estimation or further evaluation of where their pain is coming from and how we can best treat it.
Have you seen changes in how physicians would address these issues since you began your studies to be a doctor?
Yes. Oh, yes. So when I guess the tools that we have in the toolbox when I first started, and mind you, I'm not that old in the practice, but you know, I've been around to see that there have been some major advancements with how we can do things from a minimally invasive perspective to really try to provide curative measures, whereas before it was more of a kind of a treatment type issue. Okay, one of our mainstays that we do in interventional pain is that we actually do a lot of epidurals, and if you don't know what epidural is, it's like a cortisone shot for the nerves in your spine. Okay, so what that therapy does is it helps reduce inflammation, it helps reduce swelling, it helps reduce irritation over the nerve, and allows the body to kind of reset at that level of the nerve to where you don't have those pains like sciatica, which is a common issue that we treat. Now, the lifespan of this type of procedure, an epidural that is about 3 to 6 months. Okay, and patients will hear that and it's like, well, doc, you're just putting a Band-Aid on the problem. And my response to that often is that, you know, you go to your mechanic to get your oil changed every 3 months, right? If you can avoid having an all-out surgery, that in some cases is a life-altering event, because once you have back surgery or neck surgery, that will, you know, forever change your anatomy in your spine. So if you can avoid and push that off as long as you can by just, you know, getting, I guess, your oil change, and if we stick with that analogy, every, you know, 3 to 6 months or something like that, then I think you're doing your body a service because you keep it native to its natural anatomy. Okay, now that's how it was when we first started. When I first started in this business, that we did a lot of epidurals, and we still do a lot of epidurals, but what it has advanced to is really minimally invasive therapies where I can actually go and make a very, very small incision and actually remove some of those bone spurs or remove some of those bulging discs that may be pressing on the nerve without having to make a large incision, show some type of instrumentation, and really give defining therapy to a patient that allows them to be able to regain some of those activities that they once couldn't do.
That sounds good to me, all the way that you described that. If I had that, I would definitely want to find a doctor like you and pursue getting relief from pain.
Oh, absolutely, absolutely. And I mean, it's again, it's one of those things where, you know, I guess. When you talk about pain management, the first thing that comes to mind for a lot of patients is pills. You know, pills. You know, this guy's going to get me, you know, hooked on some type of pills. I've also had that a lot come into my clinic. And one of the things, and one of the unique things that we do in our practice is that we don't take that approach of throwing really any pills at you to try and mitigate your pains, because we're an interventional pain management practice. And what that means is that we try to get down to the source of where the pain is coming from and fix it at that location.
That sounds wonderful, and I'm so happy that we have your office, your clinic, Interventional Pain Clinic at 113 Medical Circle, here to serve our local residents.
Yes, ma'am. It's good to be here as well.
And I know that, how long have you been with our hospital?
So we're going on, I just celebrated my 4th year with Christus.
And there's been all kinds of changes during those 4 years, just in general. And we were going to just talk briefly about our most pressing, newest thing, and that is the reemergence of this COVID, I won't say scare, but COVID issue.
Yes, yes. So it's that's the elephant in the room. You know,
Yeah.
it's one of those things where, you know, it's an ongoing fight. You know, being a part of the medical profession, even on the pain management side, you cannot ignore the impact that COVID has had on the hospital system and what it's had on us as Americans. So, you know, I'm not here to speak about any political side or anything like that. But what I would say is that our best defense against getting out of this epidemic is not any rocket science. You know, it's really social distancing, which is something I, you know, adherently you don't like, but I believe it actually works in the short term until we can actually get the vaccinations that we need. And we have the tool in front of us: vaccinate.
Okay.
You know, I know a lot of people have their opinions on those things, but from a medical standpoint, if you can get the vaccination, that gets us further down the road to avoid what we call these variants that are popping up. The biggest one on the news now is the Delta variant. And, you know, from a medical perspective, we will keep seeing variants pop up if we don't stop this virus in its tracks. And the tool that we have is, you know, social distancing, masking, and vaccinations.
Okay. In fact, our hospital in Sulphur Springs is offering a free COVID vaccine clinic every Friday morning from 9 to 11, main lobby of the hospital. That's going to go on through August 27th in the current plan, and maybe longer. And you can get any of the three major types of vaccine by coming there.
Indeed. We have the Moderna, we have the Johnson & Johnson, we also have the Pfizer, all of which are effective against treating and preventing hospitalization with the COVID virus. Now, let me speak about the hospitalization really quick. You know, it's no secret that, you know, the Delta variant is making its appearance on the stage, center stage at this point. And what that has impacted us in the medical profession is that we're seeing an increase of patients who are unvaccinated coming into the hospital and being admitted. Okay, and that's filling up the hospital beds. I don't have the specific numbers in front of us, but you know what? Again, what I would encourage us to do as citizens of this great nation and citizens of this world is to really do our part and try and help stop the spread of this virus.
Okay, thank you for your words, Dr. Johnson. And we'll continue to remind people about the good works going on in not only your clinic, interventional pain, but throughout our hospital system.
I appreciate that. Thank you for having me.
Thank you for coming in.